Let's talk about sex and menopause.
I feel more alert and motivated. I feel like I'm a better boss. I'm better at work. I'm better with my friends. Like, it's not just something that is contained within the bedroom. When you feel happy with your sex life, and content, it really does affect all aspects of your life. You don't talk about it necessarily, but it affects so many other aspects of life.
I'm Dr. Esra Çavuşoğlu, and I've been living a sober life for the past 18 years. My battle with addiction drove me to seek new methods, devices, and supplements to improve my physical and mental performance, enhance my quality of life, and ultimately live healthier for longer. From my experiences in addiction recovery, biohacking, and longevity to the latest global developments, from groundbreaking entrepreneurs to expert academics, the conversations I've had over the years are now featured weekly on Soberhead Podcast. Today at Soberhead Podcast, we discuss the very important topics of sex, skin, and sleep after menopause with Dr. Amy B. Killen. After working as a board-certified emergency physician for more than 7 years, Dr. Killen saw the effects of unchecked chronic disease on her patients and decided to transition into anti-aging and longevity medicine. She's now a leading anti-aging and regenerative physician specializing in skin and sex. As an outspoken advocate for empowering people to look and feel their best, Dr. Killen's practice involves educating people on the value of taking care of our general health, hormone optimization, regenerative therapies for sexual organs, hair and skin, and peptide therapies. Let's dive right into this enlightening conversation. Here is something that is fascinating. A huge amount of people who watch this channel frequently are not subscribed. So I want to ask you a quick favor. When you subscribe, it helps us to make the show better, access to the world-leading experts, and ultimately bring you more value. All that I ask is for you to hit the subscribe button, and in return, I promise we will make Ayık Kafa better every day. Dear Dr. Amy B. Killen. You
Yes.
like that B in the middle. Welcome to Soberhead Podcast. I met you last month, actually, in Vegas, but I've been following your work. For a while now. I listen to you in different podcasts, and I love your Instagram. It's informative and funny. So it attracts people very much so.
Thank you.
I know that you are in regenerative medicine. You are also very much tuned into women problem. How did everything start? Let's start like that so people would have a chance to know you better.
Yeah, so I was an emergency physician. So I was an ER doctor that's where my residency training was in. I did that for about 10 years. And towards the end of that, I had my 3 kids within 2 years. And I was back to work. I had to be at work at 3:30 in the morning for a 4 a.m. shift. And my husband had moved out of state for a job, and a lot of stress, not sleeping more than about 3 hours a night, not eating well, just all the things. I was kind of getting sicker and sicker. And I just realized one day, as I kind of looked out at the patients that were in the ER waiting to be seen, I realized that if I didn't start making some changes in my life, that I was going to be one of those patients in 5 years or 10 years, waiting to get seen for a chronic medical problem that probably could have been prevented if it had gotten to sooner. So I decided to learn something completely new and went towards integrative medicine and longevity medicine and hormones and eventually regenerative medicine, stem cell medicine. And so I've been doing that now for the last 14 years or so.
You also have a specialty about hormones. And menopause, actually, more so. These days, I don't know why, you can explain what happened that this menopause talk exploded.
Yeah.
Because it was not spoken that much.
Yeah, it's a great question. I've been treating patients with bioidentical hormones, for 12 plus years now. And for years, people were really not talking about it. The mainstream wasn't talking about it. But I do think in the last 2, 3, 4 years, all of a sudden you have, major celebrities and people coming out and saying, oh yeah, I have perimenopause or I have menopause and these are my symptoms. I think that this generation of women, this kind of Gen X of women who is now reaching menopause are just a kind of a different sort of women. Like, we're not going to be quiet. We're not going to just take whatever comes our way. We want more information. We want more tools. And so I think that we're demanding more of our doctors and the scientific community at large, which I think is a good thing.
Yeah, actually, it's a great thing. But I guess it's also shifted. It's like they call it a new menopause now instead of like a typical menopause. Maybe we can start with what is menopause? What is perimenopause? Because, I know how you approach to them, but my audience wouldn't. Let's start like that.
So menopause is officially once you've had 12 months without a period. That's when you're officially in menopause. But the transition to menopause starts about 5 to 10 years before that moment. So, you can start perimenopause as early as 35 and still be considered normal. Most women are about 40 or so. But essentially what's happening is your ovaries are running out of eggs, and the cells around the eggs, called the follicular cells, are the ones that make your estrogen and your progesterone and a lot of your testosterone. And so as you're running out of eggs, your hormones initially start to kind of go up and down a little bit crazy. And then as you get closer to menopause, you have a big drop off in your ability to make estrogen and progesterone. So that's why we see so many symptoms in those 5 or 10 years and then beyond.
So what are the symptoms?
So in perimenopause, initially in the very beginning—
Or how would you diagnose someone? Or can you diagnose someone?
Yeah, it's a great question. In perimenopause, the diagnosis is primarily a medical, kind of clinical diagnosis. So it's based on symptoms, age, things like that. Early in perimenopause, your estrogen tends to go pretty high. You can get these erratic, kind of chaotic estrogens, and your progesterone is starting to go down. So a lot of the symptoms in early perimenopause are related to high estrogen compared to lower progesterone. So things like, it's like moodiness and anxiety and difficulty sleeping, insomnia. Periods can become erratic. You're not really sure when they're going to happen. Your breasts are sore. You have really bad PMS when maybe you didn't before. So that's usually kind of early perimenopause. And then as you get closer to menopause, then your estrogen has started going down as well. So you have both low estrogen and low progesterone. And so that's when we see the classic, like hot flashes and night sweats and joint pain and muscle aches and weight gain and continuation of some of the other insomnia and things like that. But the symptoms of actual perimenopause and menopause, there's like 30-something symptoms. I mean, it could be anything from dry, itchy ears to, heart palpitations to brain fog. Like there's so many symptoms.
I took a note. I was listening to some other people and they say like there's 36 different symptoms.
Yeah, that sounds right.
Scary enough that the risk of chronic diseases such as inflammation, visceral fat, blood pressure, cholesterol, it's so many things. Many things. Any of these starts at the perimenopause stage?
Some of them do, like bone loss, for instance. Your bone loss really starts during perimenopause. And so it's, a lot of women don't even know it's happening. Obviously, it's a silent kind of thing that's happening, but you're losing quite a bit of bone before you even get to the point where your estrogen is all the way down. Certainly cholesterol and lipids start to go up during this phase. Blood sugar starts to go up. Blood pressure starts to go up. Visceral fat, so the fat around your organs, starts to go up. So a lot of this starts in perimenopause, and then it just continues and, gets worse in menopause.
Is menopause needs to be a negative experience?
It doesn't have to be a negative experience. I think there are a lot of tools that you can use to fight it. However, I do think that what's happening in your body is not a good thing. I don't think that Mother Nature was really thinking about us living to be, 80 or 90 years old. Essentially your ovaries stop working at 50. And humans are some of the only animals that go through this transition, kind of midway through their lives where their hormones that they really need just kind of stop being available. Most animals, that doesn't happen to. And I think, it probably goes back to in the old days, we didn't live much beyond 50, so it didn't matter. But now we're living so much longer. Unfortunately, when you don't have estrogen and then to a lesser extent progesterone and testosterone, you are breaking down multiple systems in your body. Your body is becoming less resilient. You've lost this like shield that was protecting you. So you have to be much more proactive. You have to move from being kind of like, hey, I can just hang out and my bones will be super strong without me doing anything, to I have to really take action and do weight training and, all the things. You have to really think about how am I going to preserve the function of my body.
Is it why that we live longer than men, but we're longer sicker than men?
Yeah, I think that's true. Women live about 5 years longer than men, but they spend 25% more time in poor health. And I really do think that a lot of that is tied to loss of estrogen specifically. Men, testosterone does go down with age too. In both men and women, starting at about age 25, testosterone starts to go down. But it's a pretty gradual decline, and it just goes down kind of slowly. So men don't have this like falling off a cliff of hormones like women do, during perimenopause and menopause. And so you can have men in their 70s or 80s who still have good testosterone levels. They're still able to make it. Whereas women after 50 or so, you can't make your own estrogen to any real degree.
So let's slowly dive into what you're really focusing, because you know what? I also downloaded Mind Valley, your course, to be able to see like, what is she talking about? Let's talk about sex. What's going on with women? Sex and menopause.
In the perimenopause, menopause transition, about 30% of women just kind of stop having sex. And some of those women will start back again after menopause, but most of them don't. We see this big drop off in libido, an interest in sex, as well as ability to get aroused. So you just don't have the blood flow that you did. You don't have the lubrication. It's not as, it can be painful. So women become less interested in sex oftentimes, at around age 45 or 50. And it's a real problem. And some people aren't worried by it, but some people are. And so that one of my missions is to be able to help the ones who are worried and who want to have, a continued intimacy with their partner for long term.
And I think you're also mentioning that, having a good sex life, whether with a partner or alone, it's a measurement to a quality of life.
Yeah, I think so. Sexual health kind of sits in the middle of, in my view, it's in the middle of all the different types of health. So you have physical health and mental health and emotional health, spiritual health. You have like social health, so partner health, and then environmental health. And all of those things influence sexual health. And so you have to have all of those things kind of working and healthy to have a healthy sexual health. And also, when you are sexually healthy, it kind of positively feeds out into all of those things to influence them as well. So, we see people who are sexually healthy, and by that I just mean you have a good relationship with sex. Maybe you have a partner, maybe you have sex with yourself, but you have a good relationship and you feel good about it. We see improvements in everything from blood pressure to immunity to less depression, less anxiety. People get sick less often. They get divorced less. So there's just a lot of things that happen when you feel good, in your own skin and in your own sexuality.
So how did you decide to very much focus to that area of menopause?
That's a good question. So I was in Portland, Oregon. I had just opened my clinic seeing hormone patients primarily. And a lot of these women and men, both, I was seeing both, would come in, initially they would come in with some kind of like major problem. They were having, low energy and weight gain, and they were feeling miserable, and, they're having all these hormonal problems. And so I would start them on hormones, and I would give them some health, tips for healthy living and supplements and whatever. And then they would come back oftentimes in like 3 or 4 months feeling better, like they were out of this survival mode. Their fatigue was down. They were losing weight. And they would say, now that I'm feeling better, can you please help me with either my sex life or my skin? And they always asked about one of those two things. It was like once they kind of reached a certain level of health, they wanted help with this next level of health. And so I started just kind of researching it, like what can I do from this integrative toolkit with hormones, with other, regenerative medicine, things like that. And I realized that there was a lot that I could do coming from not from, from urology or dermatology, but really from a more kind of integrative medicine approach. And so I became very interested in sexual health and also skin and hair.
If the desire starts getting lesser and lesser because of the dropping probably not only estrogen but testosterone as well, and probably at the perimenopausal time, correct?
Yeah.
So what do you do to support women?
We meet with patients, take a good history, see what's going on. Certainly hormones can be a big part of it. Estrogen and testosterone specifically are involved in multiple different facets of the kind of sexual response curve. There are also other things, obviously, social problems, emotional, mental health. Stress is a big one for women. Just being able to kind of relax is very difficult for women. There's to-do lists are always in our heads. So that's something else that is big. So, taking a good history and figuring out, where we think the problem is primarily coming from. And then if it's a physical kind of problem that we can look at, we'll check hormones. Checking hormones in perimenopause is not as helpful. Some of them, because they're so erratic, they're going up and down so much. Like hormones like estrogen and progesterone, they may be low one day and high the next, and that's totally normal. But testosterone is usually fairly even. And we'll check other things like thyroid, for instance. Low thyroid is a very common cause of low libido and sexual dysfunction, and people don't really know about that. So we'll do kind of a full workup on all the labs and see if anything shows. If it is, then we can start. Perimenopause will often start with progesterone and then sometimes testosterone if it's needed. And then by the time you get closer to menopause, then we usually add estrogen as well from the hormonal standpoint. And then other things that we look at is, how is your blood flow? Like how is your arousal? Lubrication is part of arousal. It's part of blood flow. So we want to optimize blood flow by making sure that, the person is getting enough nitric oxide, which is going to help to open up the blood vessels and get blood flow to the whole body, really, but to the genitals. And that's something that goes down as you get older. You make less nitric oxide. So how can we increase nitric oxide, whether it's through exercise and exposure to sunlight or taking certain supplements or eating certain foods? So we kind of look at that as well. How do we increase blood flow so that you have better cardiovascular health is another step in that equation.
And then you start supplementing them, like you said. So can you explain the mechanism of why not only the desire is not there, that's probably the brain mostly, but also physically that, most people probably are not willing because it hurts or they don't know how to have an orgasm. Probably, there are a lot of women probably, they don't know how to have an orgasm to begin with.
True.
But, can you explain that region a little bit? What women need to do? Because you have great sayings about Freud and everything. So I'm trying to pull you a little bit toward there.
Yeah. A lot of women and men don't know this, but most women, about 75% of women, need clitoral stimulation to have an orgasm. So, we used to think, and maybe, even Freud used to think that vaginal sex and penetration and just, vaginal orgasms, like that's the way to go. Like that's what you should be striving for, that nothing else is good enough. But really, 75% of women need clitoral stimulation. And as we get older, the clitoris becomes less sensitive. So part of its blood flow, part of its nerve changes, part of its lack of estrogen in that area that's causing actual changes to the structures. But the clitoris becomes less sensitive. And so that makes you're just not as aroused as easily. And then the other thing that's happening is that the blood flow goes down. And again, estrogen is helping to control blood flow. So is nitric oxide. But essentially, you're not getting as much blood flow. And in order to get lubricated, that's a blood flow issue. So blood goes down. And part of that essentially causes vaginal lubrication. So when you don't have blood flow, you don't have the clitoris engorging, you lose sensitivity, and then you don't have the lubrication either. So sex becomes painful. And add on top of that, the actual vaginal tissues start getting dried out and atrophied. The cells are no longer plump and elastic. They kind of become fibrous and they don't extend easily. And so sex becomes painful. So you have several things that are happening all at one time in those same time period during perimenopause and menopause that starts to make sex less fun for women. And if it's not fun, then, we don't want to do it.
Sure. Because in every program that we look into menopause, there's obviously bazillion remarks under these YouTube channel, like, it's a natural thing. It's not natural. You hurt women. You doctors are pushing medication to the women. But this is something different. We're not talking about like, your hormones needs to be all in a great place because, you don't want to get old, whatever. But this is like you're 50 years old and your sex life is like suddenly ended. It affects your partnership, like you said, because 50 is early. I'm 53. So,
it is early. And that you have, when you have 30 or 40 or 50 years left to live, which, hopefully we'll continue to have that, it's early to lose something that for many people is very important. And it makes you feel good about yourself. Your self-esteem is tied to it, your partnership. There's a lot of things tied to our sexual health that we don't even realize until it's gone. I've had patients, men and women, that have gone, years without having satisfying sexual relationships. And then when I help them to be able to have sex again and it's pleasurable, they come back and say, this is great for my partnership, for my marriage. But what I didn't realize is it's actually, I feel more alert and motivated. I feel like I'm a better boss. I'm better at work. I'm better with my friends. Like it's not just something that is contained within the bedroom. When you feel happy with your sex life, and content, it really does affect all aspects of your life. You don't talk about it necessarily, but it affects so many other aspects of life. And the truth is that we can give low-dose vaginal estrogen. It's very safe. It doesn't get into the rest of your body. I think every woman over the age of 50 should, at least have access to low-dose vaginal estrogen. You take it 3 times a week, and it just helps to keep the vagina and the pelvic floor in a good place. It also reduces your risk of having urinary incontinence. We know where your urine is leaking for no reason. It reduces your risk of recurring UTIs. So it's not just about sex. It's also about, just health of the pelvic floor. And it's super simple, and yet most women still don't have access to it.
Yeah, or for some weird reason, scared of this word of estrogen.
Exactly. Yeah.
Can you please explain, because recently things shifted and I couldn't yet get a great explanation to my audience from the other doctors that I was doing this topic. Everybody knows what happened in 2002, I guess.
Yes.
But then it shifted again. And recently there are some articles came up.
Yeah. So in 2002 was the Women's Health Initiative. That's the big study that came out, and the study was stopped early because they were concerned about, it was an estrogen study, estrogen and progestins, and they were concerned about increased risk of breast cancer, heart attack, strokes, dementia, and blood clots. And so they stopped the study and said estrogen and progestins are dangerous. We should not be on them. And so 88% of women who were taking any kind of hormone replacement stopped taking their hormones. And, now it's been 22 years since then. We've had multiple studies, that have looked back at the data from the Women's Health Initiative. And we've actually learned that, in regards to breast cancer, the women who received estrogen without the progestin piece, so progestin is like progesterone, but it's a synthetic version. The women who received estrogen alone actually had a 29% reduced risk of breast cancer. So the estrogen did not cause breast cancer. In fact, it was associated with a decreased risk of breast cancer. And the problem child in the whole Women's Health Initiative was this synthetic progestin, which we don't use anymore. We just use bioidentical progesterone. But the progestin contributed to the increased cardiovascular disease, the increased breast cancer. It made the blood clot risk worse. So a lot of the risks that we thought were there were because of the progestin. And then a lot of the risks were also because the median age of women in this study was 63 years old. So women go through menopause at 50, and most of the women in this study were 63. So they were 13 years out from menopause, and they hadn't been on hormones. And when you wait 13 years, after menopause, you had 13 years for all this damage to be done. Your blood vessels fill with plaque, you have atherosclerosis, your bones get brittle, all these things are happening. And then if you give estrogen, especially the wrong kind, the synthetic estrogen, then it can cause some problems, increase heart attacks and strokes and things like that. So it was a multiple different problems. But what we learned from that is that we can give these hormones safely. And from that study and others, we've realized that if we give these hormones, these bioidentical hormones, estrogen and progesterone, to women early in menopause, like within 10 years of menopause onset, we actually see a 40 to 50% reduced rate of cardiovascular disease, which is the number one killer of women. We see 40% less osteoporotic fractures. We see 40% lower all-cause mortality rates in the studies that have been done. So starting hormones early is really important, and we know now how to do it.
Estrogen and progesterone is spoken a lot, but testosterone is not that much spoken, which makes no sense because we had that too. It's not like we didn't have, but for some reason, testosterone belongs to the men and the rest belongs to the women.
Yes. Yes. Yeah. Testosterone has gotten, it's become very gendered. It's a male hormone, but it's obviously not. In fact, women have more testosterone in their bodies than they do estrogen. We make about 3 times more testosterone than estrogen. Some testosterone gets turned into estrogen, but we have testosterone receptors all over our bodies as well. Our brain, our pelvic floor, our breasts, even it's everywhere. And unfortunately, there are no, at least in the US, there are no FDA approved testosterone therapies for women. I think there are in the UK and Australia, but most countries don't have it, even though we have 80 years worth of data that testosterone therapy is beneficial to women in multiple different ways.
Would you consider to do a hormone replacement therapy without a testosterone fully completed?
We check testosterone levels on women, and we do give testosterone. Yeah. We just use the male testosterone. We just use it in smaller doses. We use it off-label. So we still give it to women. We've been doing it for many years, and it's quite safe. We have a lot of evidence on that. It's just not something that everyone recognizes as needing to be done.
If you doctors are supporting women's menopause symptom and trying to bring them back to a normal, if we can, range of health, then testosterone is also as needed as the other two hormones, correct?
It is, although some women don't need it. So some women are still, you're still making some testosterone by your adrenal glands. And so some women don't need it and some women do. So I think that's absolutely important if you do need it. And even women who are premenopausal, some women need testosterone. Women who take birth control pills, for instance, often need testosterone because they have a low free testosterone. But yeah, if you need it, I absolutely think it's important. It can help with certainly libido, but also, motivation, like your desire to get up off the couch and go to the gym. It helps with muscle building and fat burning and brain fog and, all kinds of things outside of just libido and muscle building.
What type of other treatments are there to juice it up, the sex life of a woman?
I love the word. So a couple of different things. There's some home devices that I like there's some intravaginal red light therapy devices that you can get. These are just over the counter that you can buy, like devices that go inside. I'm not describing them very well, but they go inside. And it's like the red light therapy that, the panels that you put on the outside of your body, it's doing the same thing intravaginally. So it's helping with your being able to make energy and for the mitochondria and helping to restore blood flow and function. So those are great. They're very safe and you can use those at home. And then there are a number of devices and things you can go see your doctor for. I also do the regenerative injections.
Yeah, let's talk about a little bit about these.
Yeah.
Because, because my program, people know that, my approach is I'm bringing new knowledge around like biohacking, longevity, and my special field is addiction, actually.
Okay.
I know that you're really progressive in treating. These are difficult words to say when you are on the camera. Treating the vagina?
Yeah.
Or penis, because you do to both, I guess.
I do, yeah, you do. And so I use regenerative biologics, so, either stem cells or other like exosomes, which are kind of like the messenger bubbles that stem cells release that have a bunch of information and can communicate with other cells. So we use stem cells, we use exosomes, we use, growth factors, cytokines. All of these things are essentially a way to help your body start acting like a more youthful version of itself. So basically these therapies can be injected. You've probably heard about stem cell therapies, injected into your joints or things like that for many years. But I've been injecting them into the sexual organs for about the last 10 years. In women, we inject the vagina and the clitoris, and in men, we inject the penis. And we're basically trying to communicate with the tissues that are already there to become more youthful, improve blood flow, improve nerve sensitivity, make the tissues more healthy. So then, we still have a lot of research to do. There's still a lot to, unfortunately, women especially, there's less research in women's sexual health than there is men's, as you might imagine. But they definitely can help, and they're one more tool in the tool basket that can make a difference.
Are there any medication like a man takes, like Viagra for women?
There are a couple of different medications. There's one called Viagra, which is, it's based on the peptide PT141, which we've used the peptide for a long time. And you can use it in men and women, but essentially it's a peptide that works in your brain on a pathway that's connected to dopamine. They call the melanocortin pathway. But essentially it's telling your brain to be more interested in sex. So it increases libido and it also increases arousal. So blood flow as well. And there's now an FDA approved version of that for women called Viagra, and we can use it off-label for men as well.
Which I heard it. Oh, yeah, you were on a panel with Dr. Hartog and Dave Asprey. And Dave Asprey was talking about using testosterone as a cream on women's sexual organ.
Yeah, absolutely. We can use testosterone as a cream, and you can use lower doses, which just work locally, so just kind of stay in the vagina and pelvic floor, or you can use higher doses, which go into the whole body. We can also use Viagra or, the PDE5 inhibitors like Viagra, Cialis. Those medications we can use in women as well. They work great if the problem is low blood flow. So, they're basically, they're increasing blood flow. And so if that's the problem, then we can give you those medications, either apply them topically to the vagina or the vulva, or we can give you pills. But if the problem is not blood flow, if it's something else, then those medications don't work as well. But we have a few different tools that we can use, even though there aren't as many options for women as there are for men.
What are the age that people are starting getting concerned and they come to you?
Most people are around 40 to 50. I have some patients that are younger than that with hormonal problems, certainly, but for women, I think that the menopause transition is really the biggest time that women start seeing a change in their pelvic floor and in their libido. And so that's when they oftentimes come in. Unfortunately, a lot of women don't even come in asking for help. They come in for something else. And then as we're talking, I always ask about sexual health, and I always kind of probe a little bit, because I find that women and men both, but it takes a little while to be like, okay, yeah, I do need some help in this area. And so oftentimes they don't come in asking for it, but once we talk about it and I realize that this is going on, then we can discuss, what are the options to help it.
It's kind of a difficult subject to talk. Yesterday, as I told you, I was with a group of friends. We were like 5 women. We were all 49 to 53. I was the oldest one. When the sex topic came up, because I said, I'm going to do a podcast about this and that. And, so one was super open and she had no problem talking about it. The other one was talking about it, but in a way that like a science book almost. So you can see that she was nervous.
Yeah.
The third one was only giggling. It's such a difficult subject, even among women, to talk about it.
It is. And even among doctors, when you poll doctors, even doctors who are like OBGYNs, most of them don't ask very probing questions to their female patients, even though they're very comfortable dealing with female anatomy. And they'll ask, do you have any sexually transmitted disease symptoms? Are you having discharge? They'll ask things like that. But they don't actually ask, are you enjoying sex? Is it pleasurable? Have things changed? Those kinds of questions. Most of them don't ask. And I think it's unfortunate, because a lot of women don't realize that they even have any options. They just think this is part of getting older and it's too bad. And they don't realize that it is possible most of the time to improve things.
So let's now jump into the skin. What happens to the skin when we start getting older, let's say?
Yeah. Well, at perimenopause, the same things are happening kind of to the skin that's happening to the vagina. So you have less blood flow. You have estrogen is very important for collagen formation. So when you lose estrogen at perimenopause, menopause, then all of a sudden you lose a lot of the structure that your skin had. So your skin, we see this, the sagging starts. Women feel like they've aged, 5 years within 1 year when they transition to menopause oftentimes. And that's loss of estrogen. Estrogen is very important for skin. It's important for skin hydration. In fact, it's interesting. When women who have been off estrogen for a little while, when they start taking estrogen, like estrogen therapy, one thing that happens is they can have a little bit of extra water retention in their body. The cells are retaining water. They can feel a little bit bloated for a month or two. But that's because estrogen is really good at helping your cells to hold on to water. And that also goes for your skin. So it's helpful for keeping your skin hydrated. So when you lose estrogen, you lose that hydration. So all of these things, certainly you're losing collagen starting at about age 25. Every year you're losing collagen. But it really, again, kind of drops off a cliff with loss of estrogen. And testosterone. Testosterone is also really important for skin health in women and in men. But people don't even talk about the importance of testosterone for skin and hair, just like estrogen.
Can we use estrogen cream to our face?
Yes. Yeah. You can use the low concentration. So the same concentrations we use for the low-dose vaginal estrogen, like the one that's the pharmaceutical option is estradiol 0.1%. And 0.01%. That is the low-dose vaginal estrogen dose. It's one of them. You can also use estriol, which is a weaker estrogen, both in the vagina and on the face. And we have studies with both of those showing, essentially better skin aging, better hydration, better skin barrier function, better collagen and elastin when you use those on your skin.
Like a cream,
Yeah, it's a prescription for most of these. I don't know if they are in Turkey or not, but here they're prescriptions. But they're not absorbed systemically, so they stay. It stays in your skin or near your skin, so it's not affecting all of your hormone levels, which makes it safe for almost everybody.
There are mixed messages. If we take collagen from outside, would it work for skin?
So the studies are interesting on collagen. It does seem to be helpful for skin, but it's not as we thought. When you take collagen, even the collagen peptides, it gets broken down, into amino acids by your gut and as it's getting absorbed. It's not absorbed as these collagen proteins or peptides. But what seems to happen is by getting these amino acids, then your body is, for some reason, it's triggered to make more collagen. So I do think that there is some benefit to collagen. I also like hyaluronic acid taken as an oral supplement. That's another one that we have good studies on. I think it's like 100 twice a day or 150 twice a day milligrams that can help with, hyaluronic acid. You can apply it topically, and we think of that as the hydrating serum, but it actually works really well taken orally, and it hydrates from within.
I also heard people are doing collagen IVs.
Oh, I have not heard about that.
Mm-hmm.
I'll have to look into that. That's interesting.
Yeah. I was speaking to someone the other day. She was mentioning about it. She did a couple of treatments, and it really helped her, her skin and her joints and everything.
Yeah. There's different types of collagen I recommend for women to think about doing for bones, for joints, for skin. And so I, recommend products that have all three of those different types of collagen, and just, take it once a day with your smoothie or whatever. But the data is pretty good. It's not amazing, but I think it's worth doing, especially do it for a couple of months and see if you see improvements.
Do you use any peptides for the skin?
I do. I like, GHK copper is a very common skin peptide that can be given topically. So it's actually found these copper peptides are fairly common in some of the more advanced skincare that's out there now. So that's something that you can apply to the skin. It's great for skin health and reducing the signs of aging. But you can also apply GHK copper to the scalp, so that can help with hair restoration and improving the health of the hair follicles. The peptide BPC 157, which you've probably heard of, or your listeners probably heard of.
Yeah, I did a program with Suzanne Ferre.
Okay, perfect. So, it's great for musculoskeletal healing and joint pain and things like that, but it also has skin benefits as well. So that's something you can take either orally or injections, if you have access to that. Those are probably two of my favorite peptides. Zinc thymulin is another one that's great for hair that you can apply to your scalp. That's good for that as well.
I assume you're using stem cell and exosomes to the face as well.
Yeah, absolutely. I do the scalp injections for hair restoration. I do facial injections, both deep injections as well as intradermal. And then I also do the microneedling with topical exosomes, which are going to be exosomes are very small. They're kind of like the growth factors and cytokines from the stem cells, and they can be absorbed through the skin. Even intact skin, you can put exosomes on, and over the course of 12 or 18 hours, they can go through the skin barrier because they're so tiny. So I use those for skin as well.
People keep asking, because I do most of these treatments. Actually, for the hair, for the scalp injections, exosome worked like amazing for me. My hair doubled up. After the menopause, it got so thin, and I can see when we do a blowout, I can see like half of the hair is like until this half, I have double hair. It's kind of difficult to see the change on the face. Can you explain the mechanism, or how long it takes, or how many treatments? Because people expect the magical changes in one treatment sometimes.
That's a great question. And what I tell people, these regenerative therapies, whether it's stem cells, exosomes, whatever you're using, it helps it by improving the quality of the skin. So it can help with, increasing collagen and elastin and hyaluronic acid. So it can help the skin look more youthful. However, it does not increase the volume. So it's not going to help with, keeping your face nice and plump and the volume, which means it's probably not going to help with a lot of your deeper wrinkles. It's not going to help with sagging. It's not a facelift. I mean, you have to have, the expectation has to be, I'm going to come out, and after a few months, I'm going to have better, my face is going to be more glowy. It's going to look more youthful. I can help with the fine lines. It can help with kind of evening out skin tone. But it is not a facelift, and it's not filler. It's not helping with the volume piece as well. So I really do think that these therapies are great, but you still want to, consider some of the other more traditional dermatology or plastic surgery options if that's something that's interesting to you.
How do you do it, like as a cure multiple times? Probably not one time, correct?
A lot of my patients are traveling in from out of the state or out of the country. So oftentimes I'll just see them once. But the ones who are local or who can come back again, I would prefer to do it more than once, certainly. Something as easy as like microneedling and applying exosomes topically is super fast, super simple. If you could do it maybe once every 2 months for 3 times, that's going to give you better results than just doing it one time. So always with regenerative medicine, almost always more sessions are better than fewer sessions, especially with something like skin aging where, you're fighting against time. Like your time is always going to be breaking down your skin. So you're always trying to kind of rebuild it. And so you're always kind of fighting against that. So continuation, whether it's maybe once a year or a series of 3 is always a good idea to think about. What am I going to do long term? Not just how am I going to do this one time?
Do you have any suggestions to younger women, what not to do and what to do for their face?
I mean, the biggest thing is protecting your skin from the sun. And I say this as someone who knows the sun has many benefits. And I know that it's very healthy for us to get some sun. However, the sun and photo aging, the UV damage from the sun is the biggest cause of skin aging. So at least your face and your neck, your back of hands. I have a picture of myself where, my face looks good, my neck looks okay, but then like my chest has all the sun damage from all these years where I just didn't think about it. And now that, I'm 49 and now I'm like, oh my gosh, I've been ignoring my chest for all these years. And now, now I'm paying the price. But so, good sun protection. I like a good mineral sunblock with like a zinc oxide or titanium dioxide. I think that just, good skin care starting even in your 20s is a good idea. A retinoid of some sort before bed is really helpful. We have lots of data on that. It's very safe. And then some kind of good antioxidant serum for the daytime, whether that's, there's all different antioxidants out there. We also have some of the sort of biohacker supplements that are in supplements, in the serums now to the spermidine and NAD precursors and all of that. So, I think that just, investing something and thinking about it, even when you're in your 20s, and then as you get older, you tend to think more and more about it, or at least I do.
Thank you for these suggestions. So let's touch base on sleep, because sleep is like, people may not see if their bones are losing some volume or, skin, it takes a minute to understand. But sleep is like, boom. Like you get into that perimenopause, late stage of perimenopause, suddenly everything changes.
Yes. And progesterone is really important for sleep. So progesterone, I think of it as kind of like the relaxing, like the nesting and relaxing hormone. And that is the first thing that starts to go down in perimenopause because you're not ovulating regularly. And it's actually the ovulation that what's left behind after ovulation that's making your progesterone during the second half of your cycle. So you don't have that oftentimes and sleep becomes, very difficult. You're waking up at 2 a.m. and then again at 3 a.m. and, and it becomes really hard. I honestly think that sleep, of all the things that you could do, eat well, exercise, stress less, all the things that you could do to be healthy, I personally think that sleeping well is the most important of all those things. And from my personal experience, I was an emergency physician for a decade. And then before that was in school, residency in school for almost another decade. And so I never really slept for like 15, 20 years. I wasn't sleeping well. And when I left the ER and started sleeping 8 hours a night, going to bed at the same time, getting up at the same time, I felt like my entire world changed. I was able to lose weight more easily. I was able to work out. I made better food choices. My mood brightened. And I see that in patients too. I feel like when we prioritize sleep, it just makes everything else so much easier to do well.
What happened to us when we don't sleep well?
Well, when you don't sleep well, a lot of things happen. Your brain is not getting almost like washed. You have this lymphatic drainage that happens as you're sleeping, and it's kind of like detoxifying your brain. But it also causes all kinds of hormonal changes. Like we know it's mostly in men that have been studied for testosterone, but even a week of losing a couple of hours of sleep a night, you see a 15 to 20% reduction in testosterone. And we also see a reduction in growth hormone in men and women. These are hormones that are primarily made at night. And so when you're not sleeping well, you don't make them. Growth hormone, is important for your skin health, for your sexual health, your blood flow, it's upkeep of all your organs. So there's a lot of hormonal things that happen. The other big one is that your cortisol goes up when you're not sleeping well. And so cortisol, is a stress hormone. And when you have prolonged cortisol over time, it's really signaling your body to break down, everything from your muscles to your bones. All kinds of things can break down just because of that high cortisol over time, and sleep can directly trigger that.
Does only progesterone help, or do you support with other things?
Everyone's pretty different in what works for them. I think that magnesium before bed is really helpful. Like I like magnesium glycinate, maybe 300 milligrams or so before bed. I found a CBD oil can be really helpful for some people. L-theanine can be helpful for some people. There's a lot of stuff. Melatonin certainly can be helpful for some people. Everyone's kind of special cocktail is very different. But you do have to have in the perimenopausal woman, the progesterone piece is really important. You can do all the other supplements. You can do the glycine. You can do all the things. And if it's progesterone that's the problem, if you don't replace it, then you don't really see a lot of improvements.
I'm very curious about other businesses of yours. You have a supplement company, correct?
I do, yes.
Is it just HOP?
Yeah,
or
so it
it
stands for Human Optimization Project, and it's a female-focused supplement company. We just have one product right now, which is Hotbox. It's kind of a longevity stack in a pack product. And then I also have another company that is a longevity clinic franchise that we just launched our first clinic in Texas, and I'm the chief medical officer for that, and we'll be growing that pretty soon as well.
What do you offer in the clinic?
We do kind of a 360 health evaluation. We do DEXA scan and VO2 max and functional fitness testing and, all your blood biomarkers that we can think of. We do CIMT, so looking at the plaque in your arteries, the brain scanning. So essentially like a whole workup. And then we work with you every 3 months with our providers and, hormones and peptides and cardiometabolic health. And, kind of just trying to really help get the root of the problem and then prevent the most common diseases that can happen and help you feel better.
So you're not just diagnostic, you're also treating.
Correct. Yeah. We have physicians and as well as like nurse practitioners and PAs, coaches, nutritionists, all care team to work with patients. And we're pretty hands-on because I think it's easy to make a bunch of diagnoses and give you a list of problems and then send you out the door. But the problem is that most of us need more than just a list of, what our problems are. Like we need to have the actual solutions. And in order to do that, you have to have a physician or a caregiver who can work with you.
Your supplement, you didn't say much, but it's very efficient supplementation, I shall say, because everything is packaged, I guess.
Yes.
What do you have in these packages as longevity supplements?
Yeah, so it's 19 ingredients, and it was created by me. I basically was telling my patients, and as well as myself and my family, that these certain ingredients that we're using over and over again, things like spermidine and NR and quercetin and fisetin and vitamin D, B vitamins, alpha ketoglutarate. It's all the hyaluronic acid, which we talked about earlier. So it's 19 different things packaged into 5 pills. And I chose doses that have shown in the evidence to be beneficial for most people without causing side effects. And I also chose things that are not readily available in food. So we're not trying to be a multivitamin. We're not trying to replace your healthy diet. But what are the things that we need to add potentially to our food to potentially slow down some of the main drivers of aging. So, it kind of started as like a project that I was just making something for me, like to make my own life easier. And then it's become this whole thing where a lot of other women, especially, just love the ease of it, because women don't have time to buy 20 bottles of supplements and, go through all of them.
What is it there that men doesn't use?
There's not a big difference. In fact, we have a lot of men who also take HOP because they think it's so easy and great.
Yeah.
We speak primarily to women because we do a lot of education. So we're doing a lot of education around, changes in midlife and hormones and what's, the differences between men and women. So we say we're a women's product, but really about 20% of our users are also men.
So they're like small packages?
Yeah. They're just little tiny packs like this big that you just take twice a day with food. You can throw them in your bag. And it's just kind of an easy way to take, a lot of people just use it for travel and then we'll do your own, they'll do your own.
It's super easy. It makes perfect sense because I do that when I go to my travels, short or long. It's impossible to bring all these boxes or bottles. It's just like it would be like one suitcase. So like one by one, I just add them to a plastic a Ziploc bag. Yeah,
it is much easier. Now that I travel a lot, I know that you probably do too, but now that I have the, here's what it looks like these little packets. Now that I travel so much, it's just so much easier just to grab, a handful and be done with my supplements.
That's really easy. That's very smart. So it seems like you're not just a good doctor, but you're a good entrepreneur that come up with ideas.
Well, thank you. I enjoy the creativity and trying to reach more people. So that's, it's one of my missions is just to make all of this information available and make it more accessible. The information, the products, the medications, like all of this. I think women need more of these things and not less information.
But you also have a clinic in Utah.
Correct. Yes. Yeah. I have a clinic in Utah. I have 2 clinics in Utah. One of them, we do primarily hormones and integrative medicine. And then the other one is the stem cell regenerative medicine clinic.
What do you use as stem cell?
We have the option of using either the patient's own stem cells, so we can do either bone marrow aspiration or get a little bit of their fibril aspiration from fat, or we can use what are called allogeneic stem cells, so using placental stem cells. So these are placentas from full-term babies that are donated to the lab and then screened. We can use different parts of that placental tissue. We can, the amniotic fluid, the umbilical cord, the cells. There's various sort of tissues in there that we can use depending on what we're trying to treat.
Why placental and not umbilical cord?
We use both. We use both placental and umbilical cord. So the labs that we've used multiple labs, but the labs we're using now, they have like 4 or 5 different products that we'll use. Some use the umbilical cord, some use like with the mesenchymal stem cells in there, which are the stem cells that we're wanting to use. But we also have some products that just use the placenta without the cells. So it really depends on kind of what we're treating, as well as the patient's budget, because some of these things are more expensive than others.
All these information were great. Amy, what would be a message to women who are listening to you?
My main message to women is that you have so much power to change what's going to happen in your life in the next 20, 30, 40, 50 years. And, certainly menopause, perimenopause is a big change. It's a big shift, but don't think of it as something that has to make you weaker. Think of it as something that is essentially passing the baton to you to start being more proactive and more protective of yourself, because no one is there. Estrogen's not there to protect you anymore. So you really have to work harder, but it is possible and you have a lot of control over that.
That's great. Where can people find you?
So I'm very active on Instagram, Dr. Amy B. Killen, and I'm also on all the other channels as well, YouTube, Facebook, etc. I have a couple of different websites. dramykillen.com is my primary website, but then also hopbox.com is my supplement company, and Humanaut, which is like astronaut with humans. Humanauthealth.com is my longevity clinic in Austin.
We're going to add all these to the show notes. Thank you so much. You were so prepared, and you are probably always prepared, but you were so quickly explaining it. Sometimes it takes so much longer, the episodes, but this one was like you were giving the information pretty quickly.
Yeah, I talk a little fast, so sorry about that.
No, that's great, because you know what? We're using Rask to translate into Turkish, and when people talk slow, we're having a really hard time because sentence, word by word by word by word, it separates. This one is going to be much easier for us.
Wonderful. Well, this was so fun. Thank you so much for having me. I'm glad we got to meet and hang out, and hopefully I'll see you again soon.
Yeah, I'll probably come to some of these conferences in Texas, and I would love to stop by your clinic also.
Yeah, let me know, and we'll set it up for sure.
Thank you so much.
All right. Bye-bye.